his endeavors looking at the feasibility of the test and treat strategy, treatment as prevention in the United States. And I'm going to address three aspects of it, which is expanded HIV testing, linkage to care, and viral suppression. The study just finished its enrollment and data collection phase, and so I can talk about some observations related to the outcomes, but I don't have any outcome data to present yet, and I'll explain several of the reasons for that as we go along. But key features of this study is that it was to look at the feasibility of treatment as prevention in the United States, and in particular, it was intended to be a community-level treatment as prevention intervention. So there are 17 hospital sites involved for expanded HIV testing. 38 HIV test sites were randomized for the linkage to care intervention, and that was for comparing the effectiveness of financial incentives. 39 care sites were randomized for viral suppression, and the randomization was done site level. So we're comparing all the people randomized to financial incentives at one site to all the people randomized to standard of care at the comparison site. And I will not be able to talk about those outcomes today. In terms of testing, there were two aspects of it. One was expanded hospital HIV testing, and the other was community mobilization for testing. In expanded hospital testing, there were 9 hospitals in the Bronx and 8 in the DC who participated, and the feasibility endpoints were to look at the proportion and number of emergency department visits and hospital admissions where there was an HIV test, the number of new HIV diagnoses, and the number of tested patients who had previously diagnosed HIV but were not in HIV care. And what I can talk about here is the challenges. These are the example from one of the intervention communities of the wide range in the percent of people who were tested for HIV. This is through about the midway point of the study, where most of the institutions had been able to accomplish testing of perhaps 10% of the people who had attended their emergency department. There were other institutions that had done significantly better, but there was no clear overall trend. And similarly, looking at the number of HIV tests in the emergency department, there was a lot of variability among the different institutions, and there was a lot of variability month to month at each of the different institutions. This is the same circumstance in terms of the percent of tests that were HIV positive in the emergency department, ranging from less than 0.5% to over 4% to 5%, depending on the interval and the specific institution. But one of the things that we sort of determined as we were going along is perhaps we weren't looking at the correct outcome. One of the participating institutions had an individual who tried to look at the cumulative proportion of patients who had been tested for HIV. The challenge there is ascertaining the HIV status of patients who were coming in, whether you use self-report or documentation in the medical record. Then looking at the prevalence of people who have known HIV status, whether it's positive or negative, and look at the factors associated with having unknown particular status. At this institution, it was rather large. There were 3 adult hospitals and 1 children's hospital with more than 300,000 annual emergency visits, more than 90,000 admissions, and 2.5 million annual outpatient visits. So all of these were captured in one central medical record system, and they tried to look at people who had known versus unknown HIV status in terms of figuring out who needed to be tested and what happened over time. In their experience, this is up to the beginning of the study, showed a significant increase in the cumulative proportion of unique patients who've been HIV tested, so that by the time this study started, about 25% of all the people in this large healthcare system had already been tested for HIV. And as you see on the bottom line, we're also looking at an increasing denominator over this period of time, from about 60,000 unique patients in 2003 to nearly 76,000 patients in 2011. This was another study that looked at a similar kind of feature, and this was done not at one of the study sites, but in Cincinnati, that looked at cumulative testing in the emergency department. And on the bottom line on the graph, you see basically the people who were tested by this actual testing program in the emergency department over about 6 years, which ended up at a cumulative level of 20%, but over that same time period, nearly 80% of people reported that they had had a previous HIV test. And so ascertaining, this is again by self-report, and so it's not clear whether they clearly had evidence of it or not, or just thought they'd been tested, but it poses a challenge to figuring out who needs an HIV test. In terms of our community mobilization, one of the things that I haven't heard talked about here very much is how often people need to be tested. I think it's unreasonable to expect to test everybody every year. In this particular study, which was targeting high-risk populations of men who have sex with men in both communities, it was decided to attempt to promote testing twice a year. And the question of testing frequency really depends on several factors. One is which population, the next one is which test, and the third one is which specimen or specimen type. And just to show some examples of how this sort of led to, we don't have a specific recommendation, we don't know yet what we should be saying, but in CDC's analysis of national HIV behavioral surveillance among men who have sex with men, this is among 680 men who were unaware of their HIV infection in 21 cities back in 2008, stratified by the time since their last HIV test. And what you see here is that 45% of these men who were HIV infected but unaware had been tested within the last 12 months. And despite having received a negative test result, they were HIV infected. And in this population, only 16% of those with HIV who were unaware of it had never been tested. And so the question is, how often should we be testing people? Part of that depends on the incidence in the population. Part of that depends on how frequently men are being tested. In this example from Seattle, they looked at the sensitivity of various HIV tests and specimens among men who have sex with men who are tested frequently. The average inter-test interval among these men attending an STI clinic was about 6 months. And so what happens in a high incidence population is that your probability of capturing somebody when they have very early infection is obviously much higher. So that they determined on the basis of pooled nucleic acid screening that there were 192 men infected with HIV. There was a subset where 23 of these were detected only by RNA. Of that 23, 16 specimens were available to test with the fourth generation antigen antibody assay. 15 of those 16 were picked up with the fourth generation assay, but only 169 or 88% were picked up by a serum antibody immunoassay. This is a third generation laboratory test, and only 80% were detected by the oral fluid rapid test. So the difficulty with this high incidence population is, depending on the test, you might miss as many as 20% of the people who were infected at the time they were tested and erroneously give them a negative HIV test result. To go on to the other aspects, the linkage to care and the viral suppression, and look at what are relevant outcomes here, this was really a lot more challenging, and this study is attempting to use surveillance data to measure these particular outcomes. We obviously have a great example of how to optimize capture, and that's going to be presented here later with more information, but the crucial features in Julio's paper was that they have a fully subsidized healthcare system, centralized laboratory monitoring, centralized distribution of antiretrovirals, access to heart, and validated prescription refill compliance. We have none of that information in terms of the TLC-Plus study. And so the relevant outcomes that are pointed out in Julio's paper obviously are incidence and morbidity and mortality, and the things that we were able to measure as outcomes in this study were just linkage to care and viral suppression. And talk with me about last year's conference where everyone basically presented their cascades, and these are the surrogate measures that we're looking at in terms of outcomes for the treatment as prevention kinds of studies. And what we attempted to do with this study is to use surveillance data. First of all, this allowed us to do research in the real world community. The probability of capturing a separate data collection system for these two very large populated communities would be very, very difficult. Surveillance data, we hoped, would allow us to evaluate public health effectiveness rather than just efficacy in a small group of study participants. And then in the U.S., we do have some strengths in our surveillance system. There's a well-established reporting system nationally. There's been broad adoption of surveillance laws in the U.S., including local strengthening of laws requiring laboratories to report test results, both HIV test results, viral load results, and CD4 results. And this is sort of a map right now of the states in the United States that are requiring reporting of all values with specific numbers of both CD4 and viral load. Previously, some states had required only reporting of abnormal values like low CD4 counts or elevated viral loads as opposed to having the specific values. But in these two jurisdictions, they required both the reporting of all viral load values and all CD4 values. The resources that it took from CDC our centralized data reporting system that CDC has called the Electronic HIV/AIDS Reporting System, where there were dedicated and knowledgeable programmers, where they had documentation of what they were doing. But in each of the communities, both the two intervention communities and in the non-intervention communities used for comparison, there was considerable in-kind contributions of staff time. And obviously the National Institutes of Health, with their resources, allowed for some additional staffing for data entry and management. And then the data will be analyzed by statisticians statisticians and data managers at Sharp. In New York City, there was a mature surveillance system with established processes, and they had electronic uploading of data from local laboratories into their electronic system, and so everything worked out really relatively well in capturing the data. In Washington, many of the patients were from surrounding states, Virginia or Maryland, and the state laws required the labs to report to the jurisdiction of residence and not to the place where you had the test done. And since our analysis was randomized by site, we needed to capture where the test was done as opposed to where the person lived. They had a new system and they strengthened it in 2008, but the processes were not as well established as in New York. And then looking at for the non-intervention communities in Chicago, one of them, they changed their laws during the study. Houston, the data was largely managed by the state of Texas, and they had consistent and complete and timely data. Miami was missing many of the laboratory reports, but they weren't sure why. And in Philadelphia, they discovered there were thousands of unreported lab tests, which they managed as a result of conducting the study to retrieve them and to upload them. We don't have outcome data, but looking at linkage to care, people who were newly diagnosed, not previously in surveillance, with a new CD4 or viral load within 3 months of diagnosis, what we see is that in the intervention communities at baseline, there was already a relatively high percentage of linkage, but the percentage of linkage followed and tracked very much the quality of laboratory reporting, so that you see in Miami, the figure looks like very low linkage, but that perhaps is due to poor data. And there was a similar pattern for baseline viral suppression, which were very high levels of viral suppression in the intervention communities and in the communities with good laboratory reporting, and lower levels in the places that had poor data. And this raised one of the difficulties, which is figuring out what the appropriate denominator is. And I think this is a big challenge with everybody presenting their cascades. CDC's surveillance denominator uses all people who reported, who are not known to be dead or not known to have moved out of state. New York City did a comparison based on some indicators of care or clinical status within 5 years to see that the people were in fact still there. And what you see in the top box are each of the cascade components at CDC over a 5-year period using the CDC denominator, and in the bottom box, the New York City population. And in general, the difference is about 20% for every interval, depending on which denominator you choose. So that CDC would come up with about a 65% retained in care. New York City, using a different denominator, about 82% retained in care in 2006. CDC did an analysis, and these data were both presented at CROI this year, looking at migration after diagnosis, and this is the challenge with surveillance data, to see whether people are still in the area where you expected them. And they determined that about 10% of people, at least according to our records, ever migrated to another state, about 2.5% within 1 year of diagnosis. Some states had a net gain of people with HIV, some states had a net loss of people with HIV infection, and so this poses a challenge for the surveillance system, since our surveillance is conducted state by state. So our relevant outcomes in viral suppression, we also looked at, with respect to the financial incentives, a qualitative sub-study of individuals, and interviewed people about what they thought of viral incentives, and we identified that there were really 4 different subgroups. One was a group of people who had not been on antiretrovirals, or perhaps not diagnosed before, who did become virally suppressed on therapy. There are a group of people who were on antiretroviral therapy who remained virally suppressed after the start of the intervention. There was a group of people who were on ART and not suppressed before the financial incentives, but who became virally suppressed afterwards. And then a group of people who are on ART who were not suppressed before or after the intervention. And this obviously is going to complicate our analysis when we're doing it by site, trying to sort out which people really benefited or didn't from the intervention, and compare them to people at the sites where the intervention wasn't conducted. So the conclusions here are that the relevant outcomes in our study were clarified as our intervention moved forward. We found that monitoring public health outcomes could really only be achieved through surveillance, or at least we hope they'll be achieved through surveillance. But it wasn't easy and it wasn't inexpensive. The real data feeds, such as those from the hospitals, were fragile and often messy, difficult to analyze. But engaging both the surveillance and the research process together really helped both the monitoring and assessment at a lot of these facilities, and taught us some of the things that we need to do moving forward to improve our surveillance and ability to measure these kind of outcomes. I do want to acknowledge the HPTN 065 from NIAID and NIMH, as well as CDC, who participated in the funding of the study, and thanks for your attention.